Hello everyone, this presentation is about the benign conditions of the breast. It is produced by the JS Clinic and will be introduced by Dr. Saif. We have all the contact information here on this slide in case you need to contact regarding any inquiry or any other thing. It is according to the undergraduate level, so there will be no advanced information on. Just to know, all the information in this slide presentation has been taken from the Schwartz Principle of Surgery, the 11th edition. So, in case you need to go to the reference of the information in this slideshow, it's just easy to go to that book and you can take more knowledge about the topic because we focused on the informations that will help in the academic level of studying the surgical issues of the breast diseases, as we said previously, the benign breast conditions. So I hope that you will be helped by this slide presentation and it will summarize all the benign conditions of the breast in the undergraduate level. So there are some conditions that might happen in the breast, but actually it's not related to the breast tissue. These can happen anywhere else in the body. So we just want to mention them because you may find them in the breast. And we just want to know that this condition is not in the breast tissue, but it's related to the breast as in it's part of the body. So we have a condition that is called hidradenitis suppurativa. This is infection of the sebaceous glands. Actually, it might happen elsewhere in the body, like in the inguinal folds and the axilla and many other places. And the breast or the Montgomery glands or Montgomery ducts is one of the places where hidradenitis suppurativa might happen. So, why does this condition happen? Well, actually, it's unknown. Not all the pathophysiology of this disease is known, but it is supposed to be as a genetic predisposition. So some people are more expected to have this condition. The condition will start by involution, and then there will be inflammation, and after that all these process will happen in the ducts or in the sebaceous cysts. And after that there will be hyperkeratosis. Those will lead to obstruction of the duct of the sebaceous glands, and after that there will be distension, granuloma formation, and the next step is rupture of these and formation of sinuses and pus pocket, as we can see here in this picture where there is redness, and this is the infection, and this is the previous sites where hidradenitis happened, and it's a recurrent infection actually, and it will end by scarring, and some ugly scar will happen in the area, and it is a recurrent condition. Once the patient is cured from an attack, he will be free from abscess and infection for a period, and then it will happen again. So let's discuss the treatment. Treatment is first of all, you need to keep the area clean, and prevention of any infection is very important. But once the infection happen, as we can see here, you need to drain the abscess, because the only solution here is to drain the abscess and give antibiotic, local or systematic antibiotic, whatever according to the condition. And sometimes we need to excise the whole area, and this will leave a defect. So definitely we will need to do a flap or a graft to cover the area in some conditions. Anyhow, it's not specific to the breast. It's a condition that might happen in other parts of the body. But the next condition is the Mondor's disease. So what is Mondor's disease? Mondor's disease is, as we see here in this picture, it is a cord-like structure on the breast. So it is actually thrombophlebitis of the veins or superficial veins of the chest and breast. So, can it happen elsewhere in the body? Yes, it might happen anywhere in the chest, in the abdomen, in the upper limb, in the lower limb. So, it's not specific to the breast. What is, if it happened in the breast, we call it Mondor's disease. And if we see, or if we examine a patient with Mondor's disease, we can feel a cord-like structure, that it's hard, it is painful when we touch it, it's tender, and the area will be hot. So we ask ourselves why this happened, what is the cause of this Mondor's disease. Most of the patients, there are no obvious underlying cause, but sometimes it's due to trauma, due to infection, it is due to surgery, or in rare cases, it might be a superficial presentation of an underlying malignancy. So here, although it's a benign condition, we need to do mammography, ultrasound to exclude underlying malignancy. So, which vein is most susceptible of having this disease? We have major veins like the lateral thoracic vein, which is here, is most likely to have the thrombophlebitis or Mondor's disease. We have the thoracic epigastric vein, also is susceptible for the Mondor's disease, and we have the superficial epigastric veins. These veins are more susceptible of having thrombophlebitis, which we call Mondor's disease. Treatment: do we need to treat this condition? Usually, most of the time, it's self-limited, and the patient will be satisfied with simple analgesia, warm packing, and that's all that he needs. But sometimes it's resistant and stay, and we need to do excision, and maybe we'll send for the histopathological examination. We can use anti-inflammatory medications in some cases, but actually and usually the Mondor's disease is a self-limited condition, and so the benign conditions of the breast are all gathered under a wide or broad title called Abbreviation of Normal Development and Evolution, which we call ANDI. So ANDI means that all the conditions of the breast are related somehow to the process of reproductive life and evolution later, or when the female go into an postmenopausal period and in her elderly life. So the breast tissue, as we know, and as mentioned in the basic part of the breast lectures, it's susceptible to, or let's say exposed to, monthly change peaks in the estrogen and progesterone level. This will lead to stimulation and a regression of these hormones and involution monthly. This stimulation and involution or reduction in the hormonal level will lead to change in the breast size, let's say monthly. So some part of the breast will take the hormone more, and according to the estrogen receptors and progesterone receptors, and this will lead to formation of pathology, nodularity, fibrosis, all these conditions. So in collectively, we can say they are related to the reproductive life or the menstrual cycle of the female, and later on into her involutional period, in the postmenopausal period, or her elderly life. Most of the conditions of the breast can be divided into three parts. Normal, which are found to be within the normal, let's say, normal groups of diseases, or normal, they are considered to be normal, so they are not a disorder, don't need medication, don't need follow-up, and these conditions, whenever we find them in the breast, we can consider them as a normal condition. And we have disorders, like they are not diseases, but they are abnormal conditions, but they are also at the same time don't need treatment, don't need much follow-up as diseases, and are not much more affecting the female and her reproductive life, or don't carry a high risk of malignancy, or even don't carry risk of malignancy. And we have diseases that need treatment, that carry risk of malignancy, and will affect the patient and her life. This table will show us the classification of the Andy conditions. So starting here from the normal conditions, disorders, or even diseases, we can divide our patients into three categories. Those who are between 15 and 25, young patients, and between 25 and 40, which is the, let's say, the middle group or the older patients, and we have the group between 35 and which is the premenopausal group. First of all, in the young age group, we have normal conditions. Here, as you know, there will be increase in the size of the breast due to the lobular development, stromal development, and there will be eversion of the nipple. All these are normal conditions and will happen in any female in this age group. Sometimes there are disorders, and as we said, disorders don't need treatment, just follow up. We have fibroadenomas, adolescent hypertrophy, which means increase in the size, and nipple inversion. Be careful that nipple inversion is sometimes a sign of malignancy or a sign of chronic inflammation or infection. But if there is no malignancy or infection, it might be considered as a disorder. Diseases of the breast in this group is giant fibroadenoma, gigantomastia, subareolar abscess, mammary duct fistula. All these diseases need treatment and might happen in this age group. In the age between 25 and 40, we normally expect cyclical change because of the hormonal disturbance or hormonal peak and decrease during the menstrual cycle. Therefore, there will be change in the breast and there will be epithelial hyperplasia in pregnancy. So the pregnant female will normally have hyperplasia of the epithelial cells of the duct. Sometimes there are disorders like cyclical mastalgia, which is a very common condition that female will complain from pain during the cycle and maybe a few days before and after the cycle. She will have nodularity, especially in the big size breast, or there might be nipple discharge, which is bloody. Also in this condition, be careful because it might be a sign of duct ectasia or it might be a sign of malignancy. So first of all, we need to exclude these conditions. Then we say this is a disorder that might not need treatment. Incapacitating mastalgia means that it is a severe mastalgia that might affect the daily activities of the female, and in this case it is a disease that need treatment. In the age group between 35 and 55, there will be lobular involution and decrease in the size of the breast. There will be duct involution also. There will be dilatation in the ducts, sclerosis because of this frequent change in the hormonal level in the body, or let's say monthly change in the hormonal level in the body, and there will be increase in the epithelial turnover. Disorders in this age group will be macrocytes, which will appear as cysts, will be sclerosing lesions, duct ectasia in this age group might be within disorders that don't need treatment, nipple retraction, and epithelial hyperplasia. Diseases in this age group include periductal mastitis or epithelial hyperplasia with atipia. So if you ask me, does this condition have to be fixed to this age group? I will tell you no, it might happen. Like periductal mastitis might happen in a younger age group, and I don't need you to copy this table on heart, but what I want you to know is that each condition is most or let's say more common in a specific age group. So this is the a simple classification of the conditions according to age group. These tables will show us that there is classification of the benign disorders. So here we're talking about the disorders, and we can divide them into non-proliferative, which means that there is no increase in the number of the cells in this pathology, proliferative but without atipia. So the characteristics of the tissue or the frame of the structure is as the normal structure, but there will be increase just in the number of the cells, and atypical proliferation, which means that there will be an disfiguring in the tissue and increase in the number of the lesions. I just want you to know that the non-proliferative, which there is no increase in the number of cells, include cysts, duct ectasia, mild ductal epithelial hyperplasia, calcification, fibroadenoma, and related lesions. When there will be proliferation and increase in number of the cells, but the structure of the tissue will be the same, like in sclerosing adenosis, radial or complex sclerosing lesion, ductal epithelial hyperplasia, and intraductal papilloma. Atypical proliferative lesions like atypical lobular hyperplasia and atypical ductal hyperplasia. We'll go through these topics in the next slides. So just I want you to know that the disorders are either non-proliferative, proliferative, and proliferative with atypia. So some conditions will increase the risk to malignancy. Like if the female have this condition, that doesn't mean that she has cancer, but it means that the cancer is more probably to happen, and she has a higher risk to develop cancer than other patients. Like if we see here that the non-proliferative lesions in general don't have risk of malignancy. Sclerosing adenosis don't have risk of malignancy, but if we see later on in the slide presentation, sclerosing adenosis is difficult to differentiate from malignant lesions, so we need to take a biopsy. Intraductal papilloma don't increase the risk of malignancy, while fluoride hyperplasia increase, atypical lobular hyperplasia increase, atypical ductal hyperplasia increase, and all these conditions will increase. Lobular carcinoma in situ and ductal carcinoma in situ are a form of malignancy which the malignant cell didn't pass the basement membrane, so we call them in situ. Whenever you read this word in situ, it means that the malignant cells didn't pass the basement membrane, and these are not benign conditions and they are considered to be malignant condition, but didn't pass the basement membrane, so they are didn't in the staging, they are still in the early staging class. Breast cysts are common. It's a condition that is found in many young females, especially in the premenopausal period, like from the age of 25 and up to the age of 40. Usually it's caused by the overstimulation by estrogen that will lead to formation of a cavity which is full with clear fluid, and it is most commonly painless, but sometimes it might be painful. Sometimes it might reach to 10 cc 10 cc within it, and the fluid content might be clear fluid or bloody fluid, or sometimes it contain milk and we call it galactocele. Anyhow, the breast cyst is a benign condition and there is no risk of malignancy in this condition, and sometimes we need to treat the breast cyst, especially if it's painful or it is fluid is suspicion about if there's a suspicion about malignancy. So the treatment will include, the first step is to aspirate this fluid. How are we going to do this aspiration? We're going to choose a 21 gauge needle which will be connected to a 10 ml syringe, and there's no need for local anesthesia in this condition. And here we're going to do it under ultrasound guide to see or to use it as a guide to enter into the cyst and to be sure that we completely evacuated the cyst. The next step is to see the fluid that is aspirated. If it's clear, there is no need for any other intervention, and we just can discard this fluid and get rid of it and tell the patient that everything is okay and no need for cytological study. Otherwise, if the fluid is bloody, here we have to send it for cytology because of the risk of malignancy. And in some cases, when there is residual fluid inside the cyst after repeated trials of aspiration, or there is a hard part, like we call it complex cyst, which contain of fluid and hard part. In this condition, we need to take a biopsy. The biopsy can be taken by a core needle biopsy, and if you don't know, the core needle biopsy differ from the FNA or fine needle aspiration cytology, in that core needle biopsy take tissue sample, while fine needle biopsy takes cells only. So this is how we deal with the breast cyst. Mostly it is a benign condition. Need treatment if it's symptomatic or there's periductal mastitis. From the name, we can understand that it means that there is inflammation and infection around the ducts. So the periductal mastitis is inflammation around the duct, which is either bacterial, caused by bacteria, and we can find that it happen most commonly in the postpartum period. So if we ask ourselves why does it happen in the postpartum period, this is obviously because of the change in the breast that is caused by the dilated ducts that are full with milk, which is a high protein and fat content, and it is a media which is very proper or appropriate for the overgrowth of bacteria, especially if it is stagnated and there is no breastfeeding. So other causes, so here we are talking about the intrinsic cause that is from the duct. We have other causes for infection of the breast that might be from the skin, such as an infectious sebaceous cyst or an insect bite or whatever skin condition that might cause infection of the breast tissue, or even from the chest wall, like from the inside the chest or from the chest wall. We have the most common microorganisms that are found in the mastitis are Staph aureus and Streptococci. So why we have these microorganisms to be the most common? It's because they are found on the skin and they can go through the duct or from the skin inside to the breast tissue. That's why we can find the Staph aureus and Streptococci as the most common microorganisms. Periductal mastitis, if it is not treated, or if the condition progress, it will be what will convert into breast abscess. So what's the next step after periductal mastitis happen in the chest? There will be abscess formation. If we have a condition with chronic periductal mastitis, we call it Zucker's disease. This is not so important, but just to know, and when we hear Zucker disease, it's just that we are talking about a chronic process of periductal mastitis. How can we treat this periductal mastitis? It's simple. And first of all, if we don't have abscess and it is just an inflammatory and infectious process, we can go with antibiotics and warm compression. But if we have abscess that is formed, we need to do repeated aspiration under ultrasound guide for this abscess until the condition is resolved and the patient's condition will improve. First of all, we send this, let's say the abscess, for culture and sensitivity to know the type of the microorganism in this infection, and start with empirical antibiotic, then change according to the result of the culture. And sometimes we have subareolar abscesses. In this condition, the duct will form a sinus, and in this case we can choose either to do fistulectomy, which means opening of this tract, or we can do total duct excision. So we can excise whole the dilated duct that or the tract of the fistula that contain the abscess. Sometimes we need to do surgical drainage. Previously, it was the first choice to do surgical drainage, but now the first choice is repeated aspiration unless we have thin skin, which is red and thin. We can do puncture through it, or there is a necrosis of the overlying skin. So in these conditions, we have another cause for breast infection, which is caused by mycotic or let's say mycotic skin infection or fungal infection. This is rare, and usually it happens only in the immune compromised patient. And you know that some of the pregnancy is cause of immune compromised, is a cause of decrease in the immunity of the females. So here we have microorganisms that are known as plastomycosis or sporotrichosis. It's not so important to know the names of these microorganisms. It's just to know that someone with immune suppression due to any cause will have fungal or mycotic breast infection. The cause other microorganism which is common and we know it well is the Candida albicans, and this is usually due to a suckling infant in the breastfeeding female, and it comes from the mouth of the infant and transmit through a crack in the breast of the female, and this will result in infection with Candida albicans. How can we treat this condition? First of all, if there is systematic fungal infection, we can go with oral nystatin. If we have a local, we can choose for local nystatin. If there is abscess, as in the bacterial, we have to do incision and drainage or aspiration. And sometimes if it is extensive, we can go through a partial mastectomy with removing part of the breast. And in cases of Candida albicans, we need to remove the predisposing. Like if there is a crack or a wound, we have to remove it. And if the infant has a Candida albicans in his mouth, these are the source of infection and need to be taken away. Another condition is duct ectasia. Duct ectasia means dilated or abnormal dilated ducts. So what will happen if we have dilated ducts? There will be secretion stagnation, which means that there will be a remnant of secretion inside the ducts, pushing them into increasing their size. After that, the next step will be epithelial ulceration, and this ulceration in the epithelium will leave the duct exposed to bacteria that will leak into the periductal tissue and cause periductal mastitis or infection, as we said in the previous slide. So the consequence of duct ectasia is periductal mastitis, and the consequence of periductal mastitis is breast abscess. What will happen if this process goes for a long time? There will be fibrosis of the duct. So if we have fibrosis of the duct, there will be shortening of the ducts. So what is the next? If there is shortening of the duct, there will be nipple inversion. So one of the consequences of duct ectasia and mastitis and infection is nipple inversion due to the fibrosis of the duct. So if we want to ask ourselves, so why will I have a patient with dilated duct? We said previously that in elderly patient, it is due to hormonal influence or effect. There will be duct dilatation later on in the age, in the premenopausal period. But here it is a pathological, and it is caused by hormonal effect due to estrogen, progesterone. This dilatation due to pregnancy, hormonal abnormality, whatever, will lead to dilatation and starting the sequence of secretion stagnation and epithelial ulceration. How will this patient present to you? Usually the patient presents with nipple discharge. So if you want to ask, is there a specific color? No. Sometimes it presents as greenish, sometimes serous, sometimes it's even bloody discharge. It depends on the pathology and the microorganism and the grade of the ductal dilatation. Otherwise, because of this dilatation, there will be pain in the breast. And if the duct ectasia is a chronic condition with chronic inflammation, there will be a nipple retraction. This picture is a very nice picture showing that this is the sinus here due to infection, and the ducts are, we can see how they are dilated. This is a dilated duct and will end with abscess that will form a sinus through the skin. We have another condition which is, as we said, there is no proliferation. This is calcification. And what we mean by calcification is deposition of calcium in the breast tissue. The causes of deposition of calcium in the breast tissue might be various. One of them is due to trauma, induction of the inflammatory response that will lead to fibrosis, scarring, and deposition of calcium as a healing process. Also, it might be part of the cellular secretion and might be part of the aging process. If this calcification is less than 5.5 centimeter, or let's say 5 millimeter, we can say that this is a microcalcification. So what's the significance of microcalcification? Microcalcification is a serious condition and it is associated with cancer. That's why if we find a mammography with microcalcification, we have to take it seriously and think about underlying malignancy. Otherwise, macrocalcification, which is usually more than 0.5, which is, let's say, 1, 1.5, 2, whatever, this is a benign condition and usually doesn't indicate any underlying. This is a picture showing microcalcification. As this is, if we want to say this is a mammography, these microcalcification all are less than 0.5 centimeter. And if we want to go through this mammography, usually this calcification is inside a malignant mass. Calcification that is inside a malignant mass. This is another type of microcalcification, but this time the calcification is in the duct. It's also a serious condition and it may indicate underlying malignancy. And if we want to say, speak more about this mammography, these lines are the ligaments that are connected from the breast to the chest wall. These are not ducts, and these are the ducts and the distribution of the ducts through the breast. This is another picture showing vascular calcification. This is not related to the breast tissue but related to the blood vessel. Usually this is found in an elderly patient due to the aging process and atherosclerosis of the blood vessels, and we can see the distribution is different from the distribution of the ducts. So from its site and distribution, we can say this is a calcification of the blood vessels, a part of the atherosclerosis of the blood vessels of the breast. Fibroadenoma. And what is fibroadenoma? Fibroadenoma is, from its name, it's a fibrosis plus normal glandular cells of the breast. So it's commonly found in the age between 15 and 25, and here it is usually due to hormonal influence. Because of this rapid change in the hormonal peak and decrease, there will be areas of stimulation and involution, stimulation, growth and involution. This will lead to formation of a fibroadenoma. If it's less than 1 centimeter, here we say this is normal. And usually, if it's less than 1 centimeter, it will resolve spontaneously and no treatment is required, and we consider it to be normal. If it's between 2 to 3 centimeter in diameter, it's called a disorder. And as we said, disorder is less likely to need treatment, but also it is less likely to resolve spontaneously, and in this case we might need to go through a cryoablation therapy or vacuum assisted biopsy, which means biopsy under negative pressure. If it is more than 3 centimeters in diameter, this is a disease, and in this condition we need to do excisional biopsy to exclude malignancy. If we have 5 lesions in the same breast, like let's say in 5 lesions, about 1 1.5, 0.5 centimeter, 5 lesions in the left breast. This is disease and it will be treated as the fibroadenoma that is larger than the 3 centimeters. So 5 lesions in one breast is considered as a disease even if they are less than 3 centimeters. If we take a histopathology, it will be show that it has stroma with plenty fibrous tissue and elastic bands, as well as normal cells in the normal stromal cells and normal glandular cells, acini cells of the breast. So it is a benign condition and contain normal cells. Sclerosing adenosis is a condition when there will be a hard mass. This hard mass happens usually in the childbearing age and in the premenopausal period. This is because of the high hormonal effect on the breast tissue that will lead to increase in the proliferation in the acinar, myoepithelial cells, and the stromal elements of the breast. This effect is not continuous. There is ups and downs, and this ups and downs lead to hyperstimulation on this area and lead to scarring and a mass formation. So as we said here, there will be proliferation and involution. Proliferation and involution gradually will lead to a mass-like structure that contain this scar tissue, fibrous, collagen, epithelial cells, and stromal element. How will this patient present? Is as most of the breast condition either as a mass or as pain. So it has a no specific presentation. It might be discovered accidentally and it might have calcification with it due to this on and off condition like growing, reducing, growing, reducing. So there will be areas of calcification. What is the treatment of this condition? Because we cannot differentiate it from a malignant lesion of the breast, here we need to take a biopsy that contains tissue sample. And in the biopsy, if it proved to be an sclerosing adenosis, we don't need to do any further treatment. Otherwise, if it's malignancy, the patient will go through a further management process. So its treatment is just to exclude a malignant condition. That's all we need with sclerosing adenosis. And from its name, sclerosing means hard mass. So the radial scars and the complex sclerosing lesions are pathologies that are same in the histological criteria. So what is the difference between the complex sclerosing lesion and radial scar? It's just the size. So if it's less than 1 centimeter, we call it as a radial scar. But if it is more than 1 centimeter, we call it a complex sclerosing lesion. Okay, what is the radial scar? It is a scar like any other scar in the body, in the skin or elsewhere, containing fibrous tissue and collagen. It is a scar inside the breast tissue and has a radial or rays like the sun, so we call it radial scar. The problem is that these conditions have a similar radiological features as in the malignancy. That's why it is impossible to differentiate them depending on the imaging only. The next step is, after we find them, is to go to a biopsy, which is a core biopsy or excisional biopsy. If we find a radial scar or complex sclerosing scar, this means this is a benign condition. That's it. But sometimes it might be a clinical picture that is a malignancy, so we need to go through a further treatment. That's the most important part about the radial scar and the complex sclerosing lesion. They mimic malignancy on imaging and they need biopsy. But we have a condition that is called ductal epithelial hyperplasia. Hyperplasia means increase in the number of the epithelial cells in the duct. We have mild condition in which usually it is one layer of epithelial cells in the duct over a basement membrane. But if we find three to four cellular layers over the basement membrane, we call it mild ductal hyperplasia. If we find 5 layers or more, we call it moderate ductal epithelial hyperplasia. But if we find that 70% of the lumen or more is obstructed, we call it fluoride hyperplasia. What's important here that in the mild and moderate, they are not a predisposing factor and not risk for malignancy, but fluoride hyperplasia is a risk factor for malignant transformation. This is a slide, and as I told you, you don't need to copy them or read them, but just want you to see how many epithelial layers are in these tubes. Like this duct has multiple layers. I can't count them, but as you can see, it's not a single layer of epithelial cells. There are multiple layers of epithelial cells. This is a maybe, let's say, moderate ductal epithelial hyperplasia. This is, on the other hand, that you can see that the more than 70% of the lumen is obstructed by the epithelial cells, so we call it fluoride breast hyperplasia. This is the basement membrane, and all these are epithelial cells inside the duct. So this is a fluoride epithelial hyperplasia. Intraductal papilloma means a finger-like projection in the duct. Usually, from its name, it's a papilloma. It's a tumor, papillae-like in shape, finger-like projection, and it usually happens to occur in the terminal duct or major duct. Sorry, occurs in the major ducts. Okay, so its size is usually 0.5 centimeter, but it might be found to reach up to 5 centimeters. So it's not common to be larger than the 0.5 centimeter, but it's okay to find a 2, 3, or even 5 centimeter intraductal papilloma. Its color is pinkish tan, and usually it's attached over a stalk. Like, we will not find a sessile intraductal papilloma. Usually it's attached to a stalk, which give it its characteristic feature or specific characteristic feature. Sometimes this is considered to be a benign condition, but if we find more than one intraductal papilloma, this gives us a hint that there might be a malignant underlying condition. So, single intraductal papilloma is a benign condition and does not need any further treatment. But if we find multiple intraductal papilloma, this raises the suspicion for malignancy. What is the presentation of a patient with intraductal papilloma? Usually they present with a bloody nipple discharge, but sometimes it might be a serous discharge. Is it from all over the ducts of the breast? No, usually it's from a single duct. So if we find a discharge from a single duct, we suspect this to be intraductal papilloma. What's the next step? Next step, and the histopathology will come back with this picture, or what we call it microdectomy, and this is the stalk, send it for histopathology. And this is the papilloma with the epithelial cells. This is the duct. You see the wall of the duct, how regular, how smooth, single layer of epithelial cells. This is the basement membrane, and this is the lumen of the duct, and this is the fatty tissue, and then we will have the other ducts and lobules. I just want you to know the picture and put it in your mind. This is the stalk, this is the papilloma. So this is intraductal papilloma, which is a benign condition, and it doesn't further need treatment if we find it. Now we are talking about atypical ductal hyperplasia. So there will be increase in the epithelial cells, number of the epithelial cells, but here it has an atypical arrangement. So this is a picture that is similar to ductal carcinoma in situ, which we will talk about in details in the next slide, that is talking about the malignant conditions of the breast. But in general, it is the cancer that doesn't pass through the basement membrane of the duct. So we cannot differentiate histologically from the atypical ductal hyperplasia from ductal carcinoma in situ. But what is known to be the difference is that the atypical ductal hyperplasia usually is less than 3 mm in size. So if we find this hyperplasia or increase in the epithelial cells that might contain mitosis less than 3 millimeter, this is usually atypical ductal hyperplasia, but if it is more, we can call it ductal carcinoma in situ. So how can we differentiate? The only solution that we have is excisional biopsy. We have excisional biopsy, and as we said, this is not a malignant condition, but it increased the susceptibility to malignancy, and the patient need to be considered as a high risk group for cancer. Breast. We have another pathology which is the atypical lobular hyperplasia. Here, the abnormality or the hyperplasia increase in the acinar cells occur in the lobules, and it is atypical, which has atypical feature or arrangement inside the lobules. It's also similar to the lobular carcinoma in situ, which is also a cancer that doesn't pass the basement membrane and occur inside the lobuli. Here we have the same thing, that the only way to differentiate between them is that it causes distension to the lobular carcinoma in situ will cause distension to the wall of the lobule. Otherwise, the atypical lobular hyperplasia will not cause distension or even very minimal distension. It is a risk factor for malignancy also, and the only way to diagnose it is by the excisional biopsy. So what's the presentation? Will the patient present complaining of anything? No. In this condition, the patient will complain, be asymptomatic, and we might take a biopsy for other cause and accidentally find this pathology, so there will be no clinical presentation or no sign symptom of. This is a very nice slide that will show you that it is not a separated process, and it might be a progression from one stage into another. Here we have, as we said, the normal duct, which contain a single epithelial layer and a basement membrane. If we have increase in the layers of the epithelia, we call it ductal hyperplasia, which means increase in the number of the epithelial cells. But it has the same characteristic or same arrangement of epithelial cells within the duct. In the atypical hyperplasia, there will be disfiguring, or the arrangements will be not regular or not with the shape of the duct, but as we said, it is less than 3 millimeter in diameter. In this condition, we call it atypical ductal hyperplasia. We have ductal carcinoma in situ, which is more than 3 millimeter, and all the cells are within the lumen. There is no breach to the basement membrane. So this is condition ductal carcinoma in situ. When there is a breach into the basement membrane, we call it invasive ductal carcinoma. So we can see how it's an ongoing process from one stage into Thank you very much for being with us through this clinical presentation about the breast conditions. I hope that it will be very helpful for you, and I will be very happy to have feedbacks about what was wrong in this presentation, or what are the weak points of this presentation, so we can improve it in the next time, so you will benefit more from it. Thank you very much. I'm Dr. Saif, and this is the contact if you need to contact us, and we hope that you will stay in touch and subscribe to the channel and follow up our upcoming videos. Thank you everyone, and bye bye.